This is an excerpt of a webinar about IPR, or interproximal reduction, by Garrison Dental. Thank you to Garrison Dental for allowing us to post this excerpt. To see the full-length version, please contact www.garrisondental.com. All opinions are those of StraightSmile Solutions. We are an orthodontic consultancy company that helps general and pediatric dentists with their ortho cases and education. For help with a case, please visit www.straightsmilesolutions.com. Now, enjoy the show.
So we talked about all the good parts about IPR. Now let's talk about the pain points or the bad parts or the part you are all stressed about. And trust me, I've been in your shoes. And I like to encourage, I know most of you who are on this video are probably general dentists. There are some orthodontists I saw, but for most of you general dentists out there, I'm gonna pump you up and tell you, you got this. If you can do crown preps and bridge preps and all that stuff that I am scared to do, in dentistry, I've done it, but it's been 20 years plus, then you can definitely do IPR. It's not that hard, especially if you have the right system. So the first thing you need to keep in mind is timing and staging. And that is a personal decision. So for me, we're going to talk about round tripping in a little while, but I'm much more of a fan of let's just get the IPR done. Let's do all the big stuff at the first appointment when I deliver aligners. And I think most of you are probably thinking about IPR in terms of aligners. We do use IPR in braces, but for me, I do the IPR more towards the end, only if I need it in braces. But with aligners, things move a little bit differently, and sometimes we need to get the space up front. So I prefer to do all my big stuff at delivery. Again, personal choice. So, putting on attachments, doing IPR, bonding buttons as needed for elastics, and giving take-home instructions. I also am a big proponent of doing aligners, if possible, in just 3 appointments. So that's kind of a challenge, and some people think that's nuts, but plenty of orthodontists are doing it, and they're doing it well. So the 3 appointments would be, of course, records, which is when you're taking the records and the scan, delivery, which is when you're delivering the appliance, putting on the attachments, doing the IPR, delivering the buttons as needed, and take-home instructions. And lastly, debond. Everything in between can be totally virtual. I'm not saying, hand your patient a box of 50 aligners or 40 aligners. I'm saying you're gonna hand them maybe 10, 20, and then check in with them every aligner or 2 virtually. There are tons of great virtual apps. I actually just did a webinar last week on that topic. And if you're doing Invisalign, it comes with it. It's included. They have their own Invisalign virtual and their app. So it's really easy. And if you think that your patients really love coming to see you every 4 weeks, they don't. So, you might as well help them out. There's really no reason that you need to be seeing them in person if you can use virtual. Now, there's a few states where virtual check-ins are not legal. I don't keep up on all this, but I hear things. So of course, only follow your own dental practice act. But that's just my tip, and another reason to learn to do IPR well and learn to do it at the beginning. And another reason why I like this kit that Garrison sells, because it allows you to do IPR at the beginning. You don't have to, but at least the choice is there if you want it. Another IPR pain point is tooth morphology and ideal case selection. And we're not going to go too much into that, but of course, like we showed you that picture before, let me go back. I mean, this is so easy to do IPR, right? But if we didn't have that big embrasure right there, it would be more difficult, especially if the contact was subgingival. So just things to keep in mind. Sometimes we can't do IPR on a certain tooth. So you need to put your thinking hat on and decide if IPR is indicated for that tooth. And of course, picking, good cases, and that's a whole nother story. We're gonna go more over armamentarium later. I know a lot of people get kind of caught up in the weeds with what they need. So we'll go over that. We're also gonna go over the IPR map, which shows you where and when to do the IPR. And of course, last but not least, IPR charting. You definitely want to chart your IPR because you will not remember if you did it or you didn't do it and where you did it. And also, as just basic documentation, it is standard of care for you to chart that you removed enamel on so-and-so tooth, so-and-so surface, when you did it, how you did it, what tools you used to do it, did you finish polish, did you deliver fluoride? So you need to chart that as well. Okay, so what are some contraindications and risks for IPR? Well, lots of things, right? Obviously, unhealthy enamel or enamel with pathology or decay, probably not a great idea. A patient who's already sensitive, You can develop ledging if you do IPR improperly. You won't with this kit, but I've seen a heck of a lot of ledging, and I've definitely ledged in my day. So we've all done it. So if you use the right armamentarium, you will not ledge. So let's talk about the topic of round tripping. So round tripping is kind of a dirty word in ortho, and it's not wrong, it's just a thing. So round tripping basically means going round trip. So for example, if I take a patient, oh, let me see if I have a, thought I had a Typodont flying around over here. Okay, whenever I want one, there it is, hang on. Gotta grab one over here. I always have Typodonts, but of course this one is not crowded. But if you have a tooth that's crowded, okay, and we need to add IPR, there's two different ways we can do it. One way is to round trip, which is where we straighten the teeth by moving them forward. Then we do the IPR, then we bring them back, okay? Nothing wrong with that, especially if the teeth are stable and healthy and they're not having attachment loss, you know, no mobility, that's okay. And if you feel more comfortable doing your IPR on straight teeth, that is totally fine to do. But pick your case wisely, because on some cases that maybe are a little more compromised, if you do that, you might put them in a kind of precarious situation with the occlusion. You're maybe pushing the tooth outside the buccal or labial plate. You're making the tooth a little more loose. And that extra distance the tooth has to go, you know, all the way forward, then all the way back, can really sometimes compromise the tooth. And I have an auntie who always likes to say, this is kind of like I have one-off stories, but she had braces like 20 years ago. She was like in her 50s or 60s, and they did round tripping on her. It was braces, not aligners, and try to make space. And she ended up losing her front teeth. So she's like super anti-round tripping. So for that reason, I just want you always to be cognizant about picking the right case for round tripping. So we kind of talked about the alternatives already, but I always like to, you know, when you treatment plan for a patient, you always need to give what? Risks, benefits, and alternatives. So we kind of talked about the risks already, right? We talked about the benefits. You should be able to recite this stuff in your sleep. And now the alternatives. So IPR is never the only choice. It is a choice. There's always other choices. And you're going to get some patients, and I really actually believe that you shouldn't finalize a treatment plan until the patient has seen it. And that's something that a lot of people disagree with me about. But the patient has a right to understand their risk, benefits, and alternatives. I can show them the treatment plan, either bring them in, or you can even export an Invisalign treatment plan. I'm pretty sure there's a way to export ClearCorrect treatment plans where it's a HIPAA compliant way. I know how to do it in Invisalign. It's kind of difficult, but you know, it's definitely doable, so they could look at it from home. I think even easier is if you had a secure Zoom session and you could even do a virtual consult after you've done the records and exam and everything, but just to present the treatment plan and show them what you recommend. Then you want to have them actually sign off on the treatment plan. So I recommend typing it out, writing it out, saying, this is the treatment plan, you know, Invisalign comprehensive, approximately 8 to 14 months. You know, you can give a range because sometimes things go slower and quicker. With IPR for crowding, alternatives would be, you know, you could say distalization, proclination. You can explain what some of the other options are. And the nice thing to do also is to come up with a variety of different treatment plans. You could even do one that didn't have IPR, or you could do one that perhaps left the Bolton discrepancy and they're getting veneers on 7 and 10 or something like that. And you want to visually show the patients the options and explain why you prefer one or the other, but giving the patient choice as to what you can offer. I also want to mention, and this is something I like to hammer home a lot, if you are a general or pediatric dentist, if you're not an orthodontist, you know, what is I consider below standard of care is to only push your version on the patient. So I do work with doctors a lot on optimizing their ortho. And those of you who work with me, you know, I can get a little stubborn about this. So a lot of doctors will come to me and they're like, I only want to do IPR. I don't want to do elastics. That's not something I want to do. I'm not comfortable with it. Well, okay, you know, that's totally fine that that's what you feel comfortable with, but you still have a right to give your patient the risk, benefits, and alternatives. You need to mention that elastics are an option, or distalization, or whatever. And you can let them know that's not something that you feel comfortable doing in your office. You can say, I'm not an orthodontist. You can offer for them to go to an orthodontist to get that version explained to them if you don't feel comfortable explaining it. But you can't just omit that alternative to the patient. That would be considered below standard of care. You have to give them all the options. Same thing, if it's a jaw surgery case, potentially as an option, you have to mention jaw surgery. You can say that you don't offer that at your practice, but you have to offer to refer them out. It may not be the same price if they go someplace else, but you need to inform your patient. And if you don't feel comfortable explaining risk, benefits, and alternatives, you probably shouldn't be offering that treatment. I wrote in big letters, property of Align Technology, because sometimes they get a little squirrely when you show their ClinChecks, but it's mine, so I like to show it. So, but in any case, there's no name, but you all kind of know how Align Technology works. When you play the ClinCheck, right, the sites that need IPR are gonna line up yellow. They're gonna light up yellow when it's due. So for example, when I played this at aligner 17, these sites lined up yellow, lit up yellow. I don't know what you say that. Then later, some of the other sites lit up yellow. So for Invisalign, you have a lot of control. The nice thing about there, and I don't work for any aligner company. I have no particular affiliation with any of them, you know. But one thing I do like about Invisalign or Align Technology is that it's really easy to understand. It's really clear when it's due, and you don't have to do that now at 17. You just have to do it before 17. So I like to say it's like a library book. You need to do that IPR before it's due. So for me, I try to do it all at delivery. Now, for example, if I have a patient who's kind of fidgety and just can't sit for long periods of time, then I might not do it all at that appointment. But I know I have to get it done before aligner 17. So, you know, really just talking to your patient. Sometimes people can't sit there for 2 hours. I get that. Okay, so we talked about tips and tricks. I always recommend going 0.1 millimeters less than what they're asking for. That's just my little thing that I've learned over time. Another great tip is VPC. VPC is virtual power chain, and that's a branded term that Invisalign uses. You can ask, anytime I have a lot of IPR, if it's an Invisalign case, I'm gonna ask for virtual power chain, which is 3 millimeters of overcorrection alignment of aligners. They only do that 3 to 3, which means anterior teeth only. So if you've had IPR on posterior teeth, the VPC isn't gonna work. Remember, if you've got using VPC, you wanna, when the strip comes, oh, I should have had a strip. I had one flying around here. But you wanna rip the overcorrection aligners off and put a big VPC on them or X them out. Do not leave them on the big giant strip, because what's gonna happen inadvertently is you're gonna think they're actual active aligners and you're gonna give the patient the whole thing and they're gonna end up with crowding. You only give one VPC packet if needed at the end. So once you finish, let's say it was a moderate case. Moderate in the US goes up to 20 aligners. So that means you'd have 17 active aligners and 3 VPCs, which would be optional. You finish, you get to aligner 17, you do not give them 18, 19, 20, because those are VPCs. You go and have the patient come in, you check all the contacts, you know, with your floss. And if there's open contacts in the area where you did the IPR, in the area that would be affected by VPC, you give them one VPC packet. They wear it, they come back in a week or two later and you check it. And if you, as long as there's still contacts open, you can always give them the next one. But the consequence of using VPC, if it's not needed, is that you will actually get crowding. So just be a little careful. We've all done that. Another cool refinement tip that I've used is something called virtual IPR. Now we're getting like super complicated. But remember how I told you to always underdo it and not overdo it. So another tip, if I have a refinement and I have extra spaces, especially if they're posterior spaces, but you could do this instead of VPC if you wanted on anterior, is we'll check contacts at the refinement. If there's open contacts or light contacts, I will ask the technician for 0.1 millimeters of IPR on those sites, unless the scan picked it up. If the scan picks it up and put 0.1 as a space, then I'm fine. But I wouldn't actually do the actual IPR. So I'm gonna ask them for IPR, but I'm not actually going to do the IPR. I'm going to virtually do it. I'm gonna say that I did it, but I didn't actually do it. So that acts almost like a VPC. And if that doesn't make sense, I have a ton of videos that go into this a little bit more.